This conference will now be recorded.
Okay, welcome everybody. It is November 4th. Back where I come from, they always say, remember the 5th of November, but it's not for the same reason as here. It's because it's Guy Fawkes. So there will definitely be fireworks in the UK tomorrow night. I can guarantee it.
Wasn't he a traitor?
Well, it depends what religion you are, I suppose.
No, but I mean, didn't he lead an insurrection against the
Yes,
existing,
yes. He tried to blow up the Houses of Parliament. He
and
was
yet
one of those. He
they
was one of those
celebrated.
Catholics. He didn't like what was going on, I think, and they found him in the Houses of Parliament. And yes, that's who Guy Fawkes was. You got it, Len. Anyway, this is Rick Davis. That was a brief history lesson, and we got a lot of guys tonight, a lot of questions, so we'll move on pretty quickly. A quick thanks to our sponsors, who are Jensen, Bayer, Novartis, Telix, Blue Earth, and Foundation Medicine. I don't think I forgot anybody, and I hope they will stay with us next year because it's getting tough out there and we need new sponsors. We have two new gents tonight, and what we normally do is run through, give you each about 20-25 minutes. I'll ask you a bunch of questions, and we'll answer any questions we have for you. Allow me to ask you the questions and just sort of answer them, because we'll probably get to what you want to tell us, and if we don't, you can tell us at the end. And we'll start in the order that the two new gents arrived. So the first person we're going to go to is David. And David, can you hear me? Where are you on the screen? Speak up.
My camera doesn't work, but I can hear you.
Okay, don't worry about the camera not working. That's fine. How old are you?
75,
Okay, and where do you live?
Alexandria, Virginia.
Oh, another one for Captain Jim. Are you
My-
here through? Are you
yes,
here through Captain Jim? Is this one of your boys?
yes.
Uh,
That's 10-4, good buddy.
soon as they say Alexander, Virginia, I got your number down. So I know that we've got your email address. I know that we got you signed up. I don't have to worry about that. I've got a very good commanding officer there who takes care of all of that stuff. When were you first diagnosed, David?
August of this year.
Okay. And what was your Gleason score when you were diagnosed?
7.
Is that a 3+4 or 4+3?
There were a bunch of points. Most of them were 3+4. I think there was one 4+3.
Okay, so that makes you a 4+3. It's you always score yourself on the worst. As much as you'd like to think that it isn't, you always have to score yourself on the worst one. And what was your Gleason score?
7.
Sorry, what was your PSA?
The most recent one, 132.
Okay. And where are you being treated?
Virginia Cancer Specialist in Arlington.
Okay. And are you seeing a urologist right now, or a different type of doctor?
The urologist did the biopsy on me and then referred me to an oncologist.
A radiation oncologist or a medical oncologist?
Medical oncologist.
Okay. Who's the medical oncologist that you're seeing?
Dr. Sampat, Sampat, Karen Sampat.
And he's also at Virginia Cancer Specialists?
Yes, that's his practice.
That's his practice. And are you also registered with the VA? Or are you a vet? I should have asked you, because I know you're not
I'm
a vet.
I'm a
Oh,
vet,
you are?
retired Navy.
You are? Okay. All right. Well, that's very important because it gives us a little bit of flexibility if we want to find other doctors. Tell us about Dr. Sampat. As far as you know, is Dr. Sampat a general medical oncologist, or does he specialize in genitourinary diseases, cancers?
He doesn't specialize in genitourinary. He was recommended by my urologist. Um, he's quite accomplished. He's University of Virginia Medical School and Anderson Cancer Clinic in Houston.
Yeah, but the problem is that unless he specializes, you may not get the right treatment, because a lot of these we just found one this week, a guy, and they just don't know quite how to prescribe. Tell me a little, but we'll move on to that. So, before you started any treatment, did you have any scans?
Oh yes,
And
yes. I had an MRI in August, and then I had a CAT scan. Uh, then they did the biopsy, and after they did the biopsy, they did a PET scan on 15 September, and that's when they found out the cancer had metastasized.
metastasized. And was that PET scan a PSMA scan? Okay. And what did they find in that PSMA scan?
They found a lymph node in my pelvis. They found the cancer was in some of the regions of my pelvis. They found 5 very tiny cancers somewhere in my chest, not my lung. They found one lymph node under my collarbone. I think that's it.
Okay. So they found one in a lymph node in the pelvic area. They found some bone metastases in the pelvis, 5 spots that they're not sure about in the chest, and one in the and a lymph node in the neck. Is that right?
Well, not quite the neck, under the collarbone.
Under the collarbone. Got it. Now, what, based on that, what treatment did Dr. Sampat recommend?
He recommended hormone treatment, and I just started it 10 days ago with, I'm not sure I'm pronouncing it right, begins with a C. Jim, what is it?
Casodex?
Yes,
Yes.
Casodex, 10 days of Casodex. And I
Yeah.
had a Lupron injection today.
Yes.
I had an Jiva injection today. And I
Yes.
start abiraterone and pred tomorrow morning.
Okay. And is that the extent of what he wants to do?
Yes, he's done extensive blood tests, and he's got a testosterone benchmark, and
Right.
he knows what my PSA is, and he's going to bring me in for scans to check.
Right. So let me stop you right there. This is why we want you to see a GU medical oncologist, because by my reckoning, you've got more than 4 different places in your body where we see cancer. Is it reasonable to say that?
Yes.
So
He says they're all very small, but
it doesn't matter how small they are, but
I'm just giving you information.
right, but you have more than 4 spots, yeah?
Yes.
So the standard of care and the protocol today that should at least be discussed with you, and it may not be appropriate, but if I don't know, is what we call triplet therapy. Has he mentioned triplet therapy to you?
He has not.
Okay. And triplet therapy includes chemotherapy right now when you're diagnosed with the cancer, because it gives the longest overall survival, the longest longevity. And this is a bit similar to a situation like I uncovered this week with another general medical oncologist. And that's why we want you to see a medical oncologist. And I would suggest you make an appointment to see a GU medical oncologist as soon as you can and verify that treatment. Because it's real important. If you're going to do it, now's the time that you've got to do it. We've got guys on this call who are diagnosed similarly to you, de novo metastatic, and they jumped in and they did the chemo. And it makes a difference. And, you know, these general medical oncologists, they just don't keep up. He's right to give you the standard of care that he's prescribing. The protocol is correct if you had four metastases or less. Some might argue 5. We're more conservative. We'd say 4 or less. And what we suggest is you pick up the phone and get yourself an appointment with Channing Paller as soon as you can. She's at what's it? What the hospital in what's the DC hospital? She's at
It's a branch of John Hopkins.
Sibley, right? You Sibley. So do you know about her? It sounds like you know about her, David.
Jim mentioned her.
Okay. Well, we like her the best in your area. And if she's not on your insurance, then we're going to have to figure a workaround, which we could do. But the problem is, I would be talking to somebody who's really knowledgeable about prostate cancer to ask them, should I be doing doublet therapy or should I be doing triplet therapy right now? The other discussion that you might want to have, which they may not know about, is, or has he discussed with you, is treating the primary. Has anybody discussed treating the gland with you?
Yeah, the prostate gland?
Yes.
Not really.
So back in the day, we never treated the prostate gland if you had metastasis, because in the interest of doing no harm, they felt it was unnecessary. But the research and the trials over the past 10 years or so seem to indicate that we do better when we also treat the gland. Now, you can do that with surgery, you can do that with radiation. In your case, radiation would be the choice. And it would be done probably within the first 6 to 9 months. But again, somebody I spoke to this week had no idea about this. And you know, your doctor, if you go to Dr. Sampat, he's going to say, oh, no, we don't do that. Well, he would have been right 10 years ago, but we do it now. And somebody like Dr. Paller is going to know and advise you on the timing. And I suspect we've got men in this group right now who were diagnosed de novo metastatic and have had the primary tumor treated. And that is really where we see the best results and the longevity. And that's why we try to navigate people to doctors that specialize in genitourinary cancers and in particular prostate cancer. Have you had any genetic testing?
Yes.
What have they tested you for, both inherited and somatic, or just for inherited?
I'm not sure what somatic is. They tested me for inherited and it was negative.
Okay. So the other thing they should have done, because you're metastatic, and again, it's standard of care in the NCCN protocols, is they should have sent away a sample, especially when you had well, in fact, you still have a week or so to do this. They should be sending away a sample of your blood so that we can see if you've made any mutations yourself. And you have a high enough PSA and likely a high enough ctDNA in your blood right now that we can send that off, and it is standard of care. And again, you have to refer Dr. Sampat back to the NCCN guidelines.
What is NCCA?
The National Cancer Center Network. So but the NCCN guidelines now, also the AUA guidelines, and I'm pretty certain the Astro guidelines require that if you have metastatic prostate cancer, that you get a somatic sequencing, because we're looking for any unusual markers you might have. And even if you don't, it's good information, because we'll repeat this sequencing over the course of your disease and we'll be able to see changes. So again, another demotion point for Dr. Sampat is he hasn't discussed somatic testing with you. Oh, look, Alfredo, Dr. Alfredo has put up the guidelines there for you in the chat window. The chat window, new gents, are those two little squares at the top. Click there, they'll open, and you can click on any link in there. It'll open in your browser. So that's where we are. You know, if it were me, I would be discussing those three issues with Dr. Sampat, or those two issues with Dr. Sampat, and getting myself a actually three. What do we have? We had the somatic testing, we had treating the primary, and we had triplet therapy. So we've got three issues there, all of which need some review, and I'd recommend you review them with Dr. Channing as quickly as possible.
What's triplet therapy?
Triplet therapy is ADT, which is the Casodex and Lupron you're getting. It is a second-line anti-androgen, which is the abiraterone. And then it is chemotherapy. Those are the three legs of triplet therapy. And for men who are de novo metastatic, the guideline, the NCCN guideline is 4 lesions or less. You get doublet, you get just the ADT and one of those second lines like abiraterone. And if you have more than 4, the guideline is triplet therapy. Now, you may not be fit enough for it. You may have other comorbidities, what have you, but it should at least be discussed with you. And when a doc spends his world in GI cancers, which I suspect Dr. Sampat does, and he may be very, very good, he's not up to speed when he gets GU. He's still back in the in old times. Matt asked a good question. Is radiation part of the triplet therapy tree? Not really. The treating the primary, if you're de novo metastatic, is possible, and spot radiation to metastasis is also possible, but that's sort of at the discretion of the of your your GU medical oncologist, they'll tend not to give you spot therapy unless it's something large or you've got a lot of pain. It's palliative. They'll wait to see how you do on the chemo and the hormone therapy, see if that resolves, and if it doesn't, they might do it. That's where I see it. Gents, anybody want to comment on spot radiation for de novo metastatic?
Well, I think in his case, yes, he's de novo metastatic, but he's not oligometastatic. So I'm not sure they would want to use spot radiation for him.
Right. I mean, I think Led raises a really good point, Matt. I mean, if you're oligometastatic and you've only got a couple of spots, they might well use radiation, but if they're diving in with chemo because you've got more mets, they're probably not going to do it. That's a really good point. Thank you, Lynn. Okay, questions for us, or anybody want to talk to David?
Yeah. So, David, you said your PSA was 132, the latest one. What was it when you were first diagnosed?
Let's see. I had a PSA in 2018 of 10 or 11, and then 13, and then I didn't have it for a few years. And then in 23, it was 51.
Oh, and all
A year
that
ago.
time you never saw a urologist or an oncologist?
No.
Okay. I was just trying to get an idea of what your PSA doubling time might be.
Well, it was 51 in October of 23.
And what did the doc say with the 51? Did they not recommend you for treatment?
Yes, he did.
But you didn't want to follow through?
I did, but too late. I followed through in July.
Okay. Somebody is asking, Joe Commander is asking, it would be a good idea why triple therapy is a good idea. Well, it's based on several trials, of which I can never remember. Peace is one of them, isn't it, Len? And in fact, all three of them, abiraterone has one, enzalutamide has one, I think apalutamide has one, and now each one of them has a trial. Arison's, there are 4 trials, but I forget the names. I'd have to look them up. Can you remember the other names?
Arison's is darolutamide.
Yep. And Peace is enzalutamide, right?
Yeah.
No, or abiraterone.
No, abiraterone.
Abiraterone. And what's the enzalutamide? Can you remember? As soon as we see them, we'll know them. We could tell you. But when you catch us, but the point is, Joe Commander, it's all based on trials. And
it wasn't for me. This is not for me. This is for him. I wanted to make sure that he understood why it was important.
It's based on clinical evidence, and that's why. I mean, it's important because that's what the protocol is now with ASCO or with NCCN. That's the protocol, and the protocol is adopted based on clinical trial evidence. And Matt, yes, oligometastatic is 4 lesions or less. Some people say 5 lesions or less. The NCCN guideline is 4 lesions or less. Okay. Any other questions for us? Captain Jim, can you help David connect to Dr. Pala?
I can try. I would believe that she is, I believe, on the internet on how to contact her, but I haven't looked.
All right. I will try and very quickly put the link in because I have a link for her. It's always hard to do when I am. Oh, I need to open another bloody window. Here we go. Let me open a window. Bookmarks, Pala. Paller. Okay. Okay. Try this. I don't know if this one's up to date, but here's a link for her. What's your insurance like, David?
I'm Medicare and TRICARE for life.
Okay, so if you're TRICARE for life, you're golden. You can definitely get to her.
No problem.
And let her know what you when you make the appointment. Let her know you've just been diagnosed de novo metastatic. You're with a general medical oncologist, but you're worried if you're getting the right treatment, and you need to see her as soon as possible. And then that will get her in. Okay, Stuart, can you mute, please? We're hearing your telephone. It's a very nice ring, but we don't want to hear it right now. There you go. I just put it in. That should be good at Sibley. All right. Oh, we got a hand up. We got a hand up from Brian Hack. What's up, Brian?
Yeah, is it the Embark trial that you were talking about, the EDT plus enzalutamide? The doublet therapy, not the triplet.
That was, I think it was another arm of the Embark.
Okay.
It
Well,
would have been.
There's lots of trials out there.
Yeah. It would have been, I think you're right. I think it was Embark.
And they may or may not have added steroid to that. So I can't remember either, but there was Embark, and I think the other one was Presto or something like that with darolutamide or apalutamide.
No.
Take it back, apalutamide.
It could have been.
It's like
I thought I was thinking Presto was something else. I was thinking Presto was the one with cabazitaxel versus radium-223, but I don't want to get into the weeds too much.
Okay. No, sorry about that. Yeah.
No, it's okay. It's okay. I mean, we can track. I can track the trials down for you afterwards. I just can't do it right now.
Can I ask a question, Rick?
Yes, sir.
Tell me again when you use doublet or triplet. You said 4 lesions or less, they use doublet, and 4 or 5 or more, you use triplet?
Yes.
Okay.
Yes. By and large, that's the cutoff. And what we call 4 lesions or less is oligometastatic.
But I'm more than that, right?
Well, from what you told us, it sounds like you are more than that. It sounds like you are. I mean, you said that you've got 1 in the pelvic area, you've got metastases in the pelvis, you've got 5 in the chest, you've got 1 on the collarbone, even though they're small. So what you'd need to do is you'd need to show those to Dr. Pala and ask her, does she consider you to be treated as if you were oligometastatic, or is this pattern, does this pattern warrant more?
Oligometastatic, that's when they do treatment of the primary tumor also?
No, that's separate again. So the primary tumor would be treated whether you were oligometastatic or metastatic. Enzamet, thank you, Len. Enzamet. That's the one. Anyway, look, one of the reasons we record this, David, and it should be posted sometime tomorrow, and sign up on our blog to get a notice. Go to YouTube so you can listen to this again, and it's because it's a lot to take in, but you'll be able to listen to it again before you next sit in front of the doctor, whoever it is, so that you can get this squared away in your head. But we need to move on because we've got a lot of questions and we've got another new man.
Okay.
Okay.
Yeah.
All right. Artie, you got the picture here of what we do. How old are you?
I'll be a couple of months. I'll be 55 to get my senior coffee at McDonald's.
Well, we've got a couple of men who are contemporaries of yours on here. On my screen, the man who's right next to you, but everybody's screen is different. Matt, give him a wave, please. But we've got a Matt hopefully will reach out to you and give you his email address, and you and he can talk a little bit. Where do you live, Artie?
I stay in Roseville, California. It's a suburb of Sacramento.
I know Roseville. That's where I got my brachytherapy seeds. So I know it well. And when were you first diagnosed?
I was young. I was like 49 in 2019.
Oh my gosh. Wow. And what was that diagnosis?
First, I had PSA started rising.
Yep.
Then I had what's that called? I can't remember the name of it. Biopsy. I had the biopsy, and I had, I think one of my 7 parts was positive.
Okay.
Yeah.
What was the Gleason on that?
I don't remember. I don't remember. I just,
Okay.
it might have been 4 and 3. I don't remember.
Okay.
Yeah.
And what was your PSA when this happened?
I was about 7, 8, or 9, somewhere around there.
Okay. And are you a Kaiser patient?
I'm a veteran, actually. I go to Mather.
Okay. All right.
Army. Woo-ha.
So just so that you know, or maybe that's how you got to us. We have a veterans group, which is run by Captain Jim there. And we also have a group for men under 60. So we got you covered every which way.
I think I talked to him a couple of weeks ago, Captain Jim. He was golfing or something, or bowling. I think it was bowling when I talked to him a few weeks ago. So I'm going to be in the veterans group tomorrow also. Yeah.
Oh. Captain Jim, were you bowling?
Negative, I was within the bowling alley, but I wasn't bowling.
I didn't think you were a bowler. Who knew? Who knew that Captain Jim hangs out in bowling alleys? Who knew? Anyway, Artie, tell us. So you're getting treated at the VA.
Yep.
A question for you: does that VA, is it staffed by people from UC Davis?
Well, can I tell my story right quick so you can know a little
Yes.
bit? Okay, let me tell my story. So after I had the biopsy, they recommended radical prostatectomy or something else. I think it was radical prostatectomy or the radiation. I can't remember. And I chose the radical prostatectomy, which if I look back on it now, I wish I wouldn't have had it done. I wish I'd have chose something else, because what's going on now, it didn't really help too much. So I had the radical prostatectomy done. And so what they did was not even like the radical prostatectomy, that was maybe 2022, I think. Then like not even 4, 5, or 6 months later, I had radiation done because my PSA started rising again. So they didn't get it all didn't. So what happened was I had 35 treatments of radiation therapy, and that sucked. So I did that, and then they put me on, I think it's Lupron, the 3 month, the shot every 3 months. I think I was in the shop at the Lupron and the Adrestone or something like that, Adrestone and prednisone. They had me on for Abiraterone, yeah, and prednisone, and they had me on for 2 years on that. So what happened was after the end of 2 years, and that sucked because the hormone therapy I had hot what's that called, heat flashes so bad I was like pulling off my clothes in public, like I was in my car naked. It was so bad, the heat, the hot flashes. It was so bad. So I was taking medicines for that, and that kind of calmed down a little bit, but I was still getting them, the hot flashes. That was the hot flashes, and me being really tired all the time, because I had no testosterone in my body and gained a lot of weight, gained like 75 pounds during that time. I couldn't work out because I was tired all the time, and I haven't had sex with my wife in a while because of a lot of other things, my ED and all that stuff. And that happened because of the radiation and all that. So, and then what happened was, so then after the end of 2 years, was this April? I think April of this year, April or May, I hit the 2 year mark with the medicine. But then when I went a couple of months later and had my PSA, I actually also went to the prostate conference in LA, and that's how I found out about this group, the prostate conference.
Okay.
Table. I was at the table with the young lady, and so she told me about the group and the veterans group, and that's how I found out about this. But so after that,
I know you sat next to me.
I did
at the back. Oh yeah, I got you.
I did, yeah. I sat in the back. So so then so fast forward to now, I'm going to at the conference they suggested to get the PSMA because right now I have an elevated, what's that 0.8, but I learned at the conference that the doctors wanted 0.2. So I've had the blood work done. So actually on Wednesday, I'm going to see the hematologist, which I think I need. I'm like the other guy. I think I need a team of doctors because all I have is a hematologist. And just from this little 20 minutes of you talking, I'm like, there's so many other things that I could have probably went different routes or had different, because all I have is a hematologist. So I see the hematologist on Wednesday, and I asked her about the PSMA, and she was like, yeah, but you have to be 0.1. Then I asked her about Provectovol or something like that, and she was like, well, if you do, it's some Provectic or something like that. And then I said, well, she said, well, I'll put you on that. You still have to do the hormone treatment. I said, well, I'm trying to avoid the hormone treatment because I was on it for 2 years, and I don't want to go back on it if I can, maybe get some.
So let me make a few suggestions here. Okay. There isn't really a good genitourinary medical oncologist at UC Davis. So even if you're at the VA, even if you're going to the VA on Mather base, they don't have access to good docs. Unfortunately, for you, it is sort of fortunately and unfortunately, there are some good genitourinary medical oncologists in San Francisco. So what it means is that you're going to have to get your ass down to San Francisco VA, and get yourself an appointment with one of them. Find out who and let us know before they make the appointment, because we know the docs. I'm not a big fan of Amy Lynn. She sees a bunch of people there. There's a couple of other guys who now from the GU Medical Group who are there, but you need a medical oncologist, a genitourinary medical oncologist, and start working with them. They will get you onto all the right treatments.
You said a medical oncologist and a what? There's two of them?
No, genitourinary medical oncologist.
I don't know how to spell that.
Genitourinary. Okay, somebody put it, Dr. Alfredo put it in the chat window.
Oh, okay.
Now,
And
I can tell you again, because I'm leading, I can't look, but there's probably 3 of the GU medoncs. There's a really good Asian guy who is probably, and I just can't remember his name, but there's a good Asian guy, and that's probably who my pick would be right now. Who will set you straight, and he's a UCSF doc and he's a VA doc.
the thing is that I don't know, like with the VA, I don't know how that process works to be able to pick a doctor, because when I asked them, they just gave me a doctor. It ain't like they let me pick; they just gave me. You know?
Well,
don't
I
know that
think
process.
right. I think Captain Jim probably knows that better, but I also know that there at the San Francisco VA, you can tell them who you want to see when you go in. When they make the appointment, you can ask who's available.
Okay.
Okay, or ask them who are the docs, and you'll get back to them, and then let me know, and we can tell you who they are. But you need to see, and they have medical oncologists who specialize in prostate cancer, and they come from UCSF.
So there's none that's closer in UC Davis. I have to go to San Francisco. There's no closer ones.
Well, there are closer VAs, but they don't. We already know, because we've had this with other guys, that there's a VA down in
McClellan. It sucks, McClellan.
it's by the bridge there. I can't think of the name of it.
By Vallejo.
Yeah, there's a VA over by somewhere there by Vallejo, but they don't have the right docs, because we've sent people from there to UCSF, to the one in San Francisco. But man, this is your life.
Yeah.
It's not gonna, it's not that far to drive to the VA there.
Yeah, no, I just, yeah, that's fine. That's fine.
Okay. I mean, I wish we could find you someone closer, but we got, and things like all of this ED stuff we can help you with. They can help you with. The once you speak with this guy whose name I can't remember now, he'll set you up. They've got all of those facilities, and you can get to them through the VA.
Okay.
Okay. Anybody else want to jump in and talk to Artie about what we've said?
I was just going to jump in because I trained there. Artie, it's no big deal. You're just going to drive down there. You're going to go across the bridge. You're going to go to UCSF doctors at the VA campus or at the UCSF campus, and you'll be glad you did. It's as simple as that.
You said the UCFS campus. You talking about the one at Clement or the UCFS on
up on the hill? Up on the hill.
Yeah, but you
daro. It's
up on the hill. But the point is that the VA contracts with the university. So many of the attending physicians at the VA hospital are university faculty. There's a lot of back and forth.
So to get clarified, I have to go to the one on is it Clement? The one in the VA in San Francisco on off of
I think you have to start at the VA in San Francisco.
Yeah,
they see
exactly
patients. Right. The UCSF docs see patients on the VA campus. They don't see them. Now, if you go for radiation, if you needed radiation, you'd go to either Mission or Mount Zion.
Yeah.
But you start on that VA campus in where is it? Where is it, Jeff?
Park Presidio.
Right
off Clement.
Yeah,
right off Clement.
I know it's Clement. Yeah. So I do have a question though. My question is, because after I had all that done, they said it could be aggressive. But my question is, if I have the PSMA done, how can the hematologist said it might be in embedded prostate? I'm wondering how, if you got your prostate removed, can it still be there if it's removed?
Absolutely. It can be because it could have escaped from the bed before you had it removed. It could have been in the prostate bed, and now they may need to treat the bed, and they may need to treat you across the pelvis. And we need to see where, did you say you've had a PSMA scan or you haven't had one yet?
No, I haven't. That's what I'm saying. I'm going on Wednesday to see my PSA score with my hematologist at Mather, and then after that, she recommended the PSMA scan. So I'm gonna do that Wednesday, and then I'm gonna go probably Friday to San Francisco and see if I can get the other doctor, the GO,
He
whatever.
had salvage radiation. There's a problem there because they can't treat it with radiation anymore if it was in them. That's why you have to get a PSMA PET scan and find out where it's at.
Yeah.
It's probably not in the prostate area. It may be. By the way, if you get hot flashes again, I had terrible hot flashes. Rick knows about this. A lot of people here. I had just terrible hot flashes. And after a year, my oncologist finally put me on Depo-Provera, which pretty much stopped them. Though one thing that really helped was this device right here in my wrist. It's called a wave device. It's made by Ember Labs. And the thing is, with what you've got going on right now, you're almost definitely have to go back on ADT. So you're going to go back into the hot flash zone. And this device really helps a lot of people, especially at night. I used to wake up with the sheet under me totally wet but this has a night mode that goes for 7 or 8 hours. That it's EMBRLABS.com is the company that makes it.
EMDR?
EMB is in boy. EMBR.
Just put it in the chat window, please.
All right.
Just
And
put it
it helps a lot. There's also there are other hormone treatments that will work. You need to talk to oncologists about it. One guy in here, and one other person I've heard said that if you take tofu every day, it stops the hot flashes. I cannot verify that, but I've heard from 2 different people that works. I'll put it in the chat, the Ember Labs.
So
somebody else did.
This won't stop the hot flashes, but it'll reduce them. Okay, anybody wants to look at this? Soy isoflavones. Okay, it's a supplement, and since I've been taking it, it's cut down on my hot flashes. So consider it. Life extension makes it. It's very good. It's cheap.
Okay, so
you're saying I'm gonna have to go back on the hormone treatment, which I didn't want to do, so I'm probably gonna have to go back on it.
Okay, so there's a couple of things. If you get to the right doc at UCSF, there's discussions you can have that it's possible they can put you on a monotherapy treatment, so you don't have to do the ADT. There's going to be some flexibility. This is why you've got to really get yourself an expert doc. I've put a name in the chat window for you. You can see the chat window, right?
Do I see 4 or 5 names? I see it.
Well, those names, forget those names. The name I've put there for you is Franklin Wang, Huang. Okay, and I've put he treats mostly, from what I recall, he largely treats at the VA, and he's a good guy. Okay, and that's who I would suggest you try and get an appointment with him. He would be a good person for you to start with. And if you've had so much trouble with ADT the first time, you can talk to him, Artie, about doing monotherapy. Could you be considered for monotherapy? And that might be with abiraterone again, or it might be with darolutamide. There's a lot of flexibility, but your docs up where you are right now they won't have any idea about this.
Then my other question is also, I didn't have this. I've heard about it at the conference, but you guys explain again. What is you said the germline testing and the other testing.
Somatic.
I haven't had that. Somatic. I haven't had neither one of those done. How would those help me? I'm gonna ask them about.
They would tell you if you've got. Do you have cancer in your family?
I thought I know of. Not that I know of.
Okay. So the really what should have been done, or if you are, it depends on the result of the PSA test or the PSMA test. So let's not get ahead of ourselves. As far as the inherited is concerned, I'm going to put a link in there for you right now. You can follow up yourself for this link, and you can get your own inherited test Um, promise, 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 promise. Here you go. If you follow up with this link for the promise test, just click on this link and you can order it tonight. They'll send you a kit in the mail and you'll find out whether you have any inherited mutations. As far as the somatic mutations, let's wait and see what the metastasis, what the PSMA scan shows. But most likely, somebody like Dr. Wang will order that for you.
Okay. Got it.
Okay. Anything else? Because I'd like to move on because we got
That's
about
it. That's
12.
it. I'm good. Yep. That's it. That's
Anybody
it.
else got anything? Anyone else got anything for Artie?
Make sure you don't say you want your doctor involved when you go look for that free test. Because if you do, they won't send you the tube to actually test it right away. They'll have to speak to your doctor. So just don't check that box.
Don't check doctor. Okay. Don't check doctor. Okay.
Don't check.
Is that price? How much is that? Right quick.
Free.
Oh, it's free.
The price is right. It's free. It's a clinical trial that they're doing.
Okay.
At
Thank
Hopkins, and they're doing it at Hopkins and at UW, University of Washington. So, and I'm sorry I didn't recognize you. You look younger without your cap on. Okay. Oh, and by the way, Matt, who has now moved down the screen, he's a neighbor of yours in Sacramento. So you guys can have a cup of coffee sometime. Right, Matt?
Yes, down the road. Yeah, I sent you my email before, and then I logged in and out. So let me know if it's not there already. I'll put it in again for you.
Okay.
Yeah,
Okay. We're getting a Sacramento group. Okay. All
Tom
right.
Holland's from Sacramento too, from right outside of Sacramento.
All right. Okay. So I'm gonna start running down now with with the people who are. I've got to make a list. Bear with me. Give me 1 second because I've just got to make a list of these two. The first two people was David, and then Artie, and I can fill that in afterwards. And we're going to go to Mark Valens, who's got a significant update for us.
Last week, I got in a car to drive 2.5 hours, and my back was just killing me. And so when I got back to civilization, I got a MRI of thoracic spine, and basically I have extensive metastasis all up and down my spine, and totally unexpected because my PSA had only crept up from less than 0.01 all the way up to 0.06. But it's got diffuse osseous metastatic disease in the thoracic and upper lumbar spine, tumor extension into the dorsal epidural space, bone lesions in multiple ribs, numerous marrow replacing lesions. Anyways, it's not good. And it's a total surprise. My medical oncologist was floored. She doesn't know how that's possible because I wasn't having any PSA. And so I'm just now trying to find radiation oncologists and figure out what to do next. But don't quite know where to go.
Okay. Well, there's a couple of things that come to my mind right away. The first thing is we need to get some somatic testing done, updated. When was the last time you did a somatic test, Mark?
Quite a long time ago.
Okay. So when you say she was flawed, you're talking about Borno, right?
No, Dr. Barno never gets back to me, so it's my local medical oncologist. It's not a GU med oncologist.
Okay, so
But
you
she
got to
talks
get
to Dr. Barno.
you got to get yourself to a GU Medonc, man. I
Well,
mean,
I've got an
even
appointment
if
in
you
Seattle. I've given up on Dr. Borno. I've
okay,
got one with Dr. Shea in Seattle at the end of the month.
where is Dr. Shea?
It's Fred Hutch.
I don't think I know.
He just moved there from UCSF.
I mean, I would go to Heather Cheng. That's where I would go because we know her. I don't know Shea. I think he was a junior guy at UCSF. I would suggest you see Schweitzer or Cheng, Heather Cheng.
At Fred Hutch or
Yeah,
at
Fred Hutch.
UCSF?
Fred Hutch. And you don't want to wait until the end of the month.
No, we're trying to speed things up.
Okay. Try and get to them tomorrow. Tell them you're an AnCan'r person because she knows us. Tell her we've sent 200 people to our promise trial, so she owes us one. Maybe even more. All right? You could give her the message. AnCan'r sent, we don't know how many. Last count it was 150. It could be 250 by now. And she owes us one. If you cannot get to her, I will call Jim Schrate because she's involved with Zero. I think she might be on the Zero board, and Jim is on the Zero board. And Dave, and we've got another guy who sees her and really likes her. David, the younger guy who's in the under 60s group. So I've got people that can get to her for you. So try and see if you can't get to her. That would be my number one.
Okay. It's hard to get a hold of anybody up there, but my doctor has a lot more luck. I'll stick her on him and see if she
and hold on a minute. And for your benefit, I'll put her. Here's a link. There's a link to her, but she's great. She's really good. Now, what we've got to drill down on is one, we got to get somatic testing, and we've got to see if your cancer has morphed, because your cancer is behaving in a way that would suggest that it's no longer adenocarcinoma. So it's acting like a small cell neuroendocrine-like. And that's what you've got to get your docs to ascertain, because if that's the case, then the treatment that you should be discussing immediately is a platinum.
Platinum?
A platinum-based chemotherapy.
Okay.
And somebody like Cheng is going to be well on top of that.
Okay.
The other person who's going to be well on top of it, if you want, and I know him well enough because he actually specializes in this, is Rahul Agarwal at UCSF.
Uh-huh.
And I can drop him a line tonight.
Okay.
That's his area of expertise. But it sounds very much to me like you have, that's where your cancer's gone. That's why your PSA didn't go up. And that's what we're seeing. Have you had a lot of fatigue recently?
Nothing more than normal.
Okay.
And just remember, I've never had any PSA, even with the Gleason line. I've never expressed PSA.
So maybe we're wrong, and I hope we're wrong, but that's what I would be looking for. But that's why we got to get you to a specialized meadow.
Okay. So I'll try Dr. Chang or
Rahul Agarwal.
yeah.
Okay, you want me to put Rahul's? So I both Julian and I have put in a link for Chang, and
Okay.
for Agarwal, I'm just putting it in right now. Here's one. I'm sorry that I'm not putting in first the names. I just can't. I can't do it when I'm doing so much. There's a link for Rahul Agarwal as well.
Okay, great.
Okay. Anybody else want to say anything to words of comfort, words of wisdom, words of anything for Mark?
Mark, what did they do for your back pain?
Acetaminophen.
That's it?
And it's actually I take a hot bath every morning and stretch my legs over the end of the bathtub and get a good traction that way, and I'm not in that much pain. It was the driving I was in pain.
Yeah.
But once I stopped driving, it's a whole lot better.
Okay.
You see, the thing is, if we can biopsy one of these lesions and they can look at the cells, that would be really, really important to do.
Okay.
And there is a window where we can successfully treat, but we have to identify it early and treat quickly. And that's why time is of the essence here. So you know we need the somatic because there may be a mutation that would give us a clue on that, and we need to look at those cells where you have the metastasis, so that we can see if those are weird looking cells. So even though a liquid biopsy is going to give us the results for the somatic, it would help. Can I ask any of we got 3 docs on the call, and do you want to, Dr. Alfredo, Dr. Jeff, or Dr. Jack, do you want to say anything about this?
You got to get some basic blood tests if you want to rule out a neuroendocrine kind of thing. So you got to get some chromogranin A to start. You can get the other one, the NLase, I'm blocking on it. But there are several blood tests that can screen you, at least initially, while you wait to find out if you can get a biopsy or a consultation with Agarwal.
Okay.
Yeah, I agree with all of that. I have to say that as your story was unfolding, my mind immediately went to a second malignancy. That, you know, as you told the story at first, yes, it could be prostate also, but it could be some other primary. And so that needs to be laid to rest. Which is it?
I mean, wouldn't you have to do a biopsy to lay that to rest, Dr. Alfredo?
That would be the best way, absolutely. It looks like they have plenty of places to stick a needle from what Mark described. I'm not saying this happily, but it should be pretty easy to get a biopsy and lay that to rest.
Yeah.
And then a medical oncologist will be in charge, you know, leading the team.
Yeah, and I really think that with either Cheng or Agarwal, I mean, the only reason I really like Dr. Agarwal for this is because he's probably one of the front runners in terms of small cell neuroendocrine research in the country right now.
Well, do you think I should try for him first before Dr. Chang?
I think he's got more knowledge in this area. You know, there's him, and there's a very good lady. There's a very good lady over in Boston, but you don't need to go that far.
Mark, did you say you were located in Seattle?
No, we're Southern Oregon, so we're actually a little closer to San Francisco. 5.5 hours to San Francisco, or 8.5 hours to Seattle.
Yeah. So what I'm about to say is probably true both at Hutchinson and at UCSF, but and I myself am going to MD Anderson down here, but one of the advantages, I just want to supplement what Rick was saying about Dr. Agarwal, is Dr. Agarwal has the ability to walk down the hall and get another world expert, say, what do you think about this? And that unfortunately doesn't happen in rural America quite so easily.
No.
And I'm talking about literally going down the hall, and next thing you know, a second white coat is in the room and they're having a conversation about it. That's a very powerful thing in situations like yours.
I had all my radiation down at UCSF with Dr. Roach.
Oh, great.
And a lot of other good doctors down there too.
Well, I'll get off my soapbox.
That's okay.
Well, you decide, it can be difficult to switch, but the fact is Dr. Bono is really not seeing anybody, and I can lean on Rahul to take you over from Bono, and I think we can make it happen, but you just got to let me know so I can write him a note.
Let's try it, Rick.
Okay.
I prefer to go to San Francisco. It's closer, and I grew up down there, so.
Okay. Well, thank you, Alfredo and Jack.
It's neuron-specific NLase, by the way. Neuron-specific NLase. And
right.
synaptophistin is the third one, and then there's this thing called CD56. So they're all 4 screening tests for neuroendocrine prostate situation.
One of the issues with neuroendocrine and prostate cancer is I don't know to what extent it expresses because it may not be original neuroendocrine disease. It may have been disease that's morphed into small cell, what we call neuroendocrine-like. And so some of those traditional neuroendocrine markers, I don't know how well they show up. Len, do you know?
No, I couldn't answer that, Rick, but I know that for neuroendocrine, the most common biomarker is DLL3, and they do have a blood test for that. They use an anti-DLL3 antibody. Now, the distinction between small cell and neuroendocrine, and, do the biomarkers change? I don't know the answer to that.
Yeah. But that DLL3, they have a test for it, but it's not commercially available. Now, Agarwal may be able to access it because he's on that trial. But we've had a couple of guys that have tried to get into that trial, and there hasn't been enough drug, and they're on a wait list. But that's why I'm saying that, Agarwal is going to be the guy who really will know how to figure out if it is or it isn't, Mark.
Okay.
Okay, and Cheng, as good as she is, and she's great, and she's very, very nice, but this small cell stuff isn't his field. I mean, he's not part of that DLL3 trial, and there's a couple of people working with it at Memorial Sloan Kettering, and also they're working with it at Dana-Farber, but it's not readily available. Okay, last comment, and then we got to move on. Jeff Marchi.
Yeah, it is possible that he just has prostate cancer that doesn't produce PSMA, and not that it's neuroendocrine, right, Rick?
It is very possible since he's never made. But what's so weird is that we haven't seen this before, and it's crept up with him. And here's where I have a concern. I saw this happen to my buddy Nigel earlier this year. And so my antenna are waving around because we didn't think he had neuroendocrine. And the next thing we know, he's got small cell and it isn't good. So that's why I really want to get you as quickly as possible. And I will write to Rahul tonight when we get done with this. I'll write to Rahul. He's usually pretty good about writing back to us.
Great.
And see, and I'll copy you on that. Okay.
Great. Well, thank you, everybody.
It's a pleasure. And let's hope we can get some results. All right. Let's keep going because we blew our 5 minutes on that one. Joe Commander.
Okay. I finally started on hormone therapy, and I'm taking Orgovix. I started on the 21st of October. It's actually going pretty smoothly for me, which I'm thankful for. I'm doing a lot of exercise, and I don't really have any symptoms. But I had a couple of quick questions that we shouldn't need to spend a lot of time on. One is that my doctor is doesn't think I should have whatever you call it, dual therapy, and so she's not recommending that I do that. And I guess I'm okay with it if she's okay with it, which she is. But I'm wondering what you think of that. I have a what is it, 3-4 or 4-3? I think it's 4-3 Gleason score, and she doesn't think I need the second line.
What do you have in the way of metastasis?
I have two more. I've had individual ones that were spot radiated, and now I have two down sort of
In the bone, or I mean, I've got a note that you
just
had.
lymph nodes.
Okay, so that's the reason why the NCCN guidelines are kind of vague if you've only got lymphatic.
Okay.
If they were bone, there would be no question.
Right.
But we've had this issue with other guys who are considered to be T3 and not T4. If she classified you as T4, she should be giving you a second-line anti-androgen, and it's up to you to discuss with her the pros and cons and why she doesn't want to do it. If she considers you still to be T3, then unless it involves the seminal vesicles, you probably should not be. The guidelines don't include doublet.
Okay.
But it's a very fuzzy area, and if you this is this Catalia still that you're seeing or not?
That's correct.
I don't know. You might want to get a second opinion. It would be my answer. You might want to get a second opinion. Go over to UPenn and go see Vivek. What's his last name? Hold on. Vivek. Narayan. Go see Vivek Narayan at Penn and ask him what he would do. Get a second opinion from Vivek Narayan.
Okay.
Okay.
All right.
I'll put his link in here because I just opened it to jog my memory.
Okay.
And I'll put his link in. Oh, that's not going to help you because it doesn't even say. Okay, doctor. And he's a good guy. And again, he knows us. He knows us pretty well. He's a very good doc. And I would ask him but it's a very gray area, Joe. And hang in, man. You're going to do fine on the hormone therapy. You are. And I know what a big step this was when you swallowed that first pill.
Yep.
I know. And see what he says. I mean, you didn't want to do it. So, do you want to do 2 of those therapies? Not really.
No,
but
not really.
I think it's time to get a second opinion from Dr. Narayan.
Okay.
Anybody else for Joe? No hands up, no noise. We're moving on. Alan Moskowitz.
Okay, speaking of second opinions,
Yes.
my situation is my PSA has started to creep up, and I don't want to go into all of that, but I'll be having another PSMA scan in January. I basically have had a 2-year drug holiday. PSA is up to about 0.6 something. It's doubled every 3 months for the past 6 months. So I have a doctor, a man oncologist, a genitourinary guy at Sloan. I've been seeing him. But truthfully, I'm tired of going to Manhattan. Sometimes it's a real slog coming in from New Jersey. And I know that Fox Chase is more manageable, certainly driving wise. And I thought I'd ask if we know any folks there. I mean, I looked at their list. I found 4 people, but maybe there's some thoughts where I can narrow them down a bit. And I'd go there for another opinion. And in fact, I might even change if I thought the person was pretty good, only because I think it's going to be more convenient for me.
Okay, so I've got 2 suggestions for you. Okay, the guy that we've got a bunch of guys who see him. The guy that we like at Fox Chase is Dan Geynisman, Geynisman.
Yeah, he's one on my list. Yep.
Okay, so if that's where you were going to go, I probably would start with Dan Geynisman. I'm just putting his link in the chat window for you.
Is there a number 2 guy?
I would probably go to Narayan at UPenn.
Yeah,
maybe.
If I needed a one-time second opinion, that's workable. I could probably go into Manhattan and see, Dr. O. I haven't seen him in a while. I haven't talked to him in a while, but I did consult him. What about this?
Hold on a minute. Time
Yep.
out.
Yep.
Dr. O is no longer in New York. Dr. O has moved to New Haven, to Yale, but he's seeing patients in Stanford, not Stanford. Where is it? Greenwich.
Greenwich, yeah.
Right.
Rick, he will continue to be at Mount Sinai until the end of this year.
Okay.
All right. So we forget him then. That's
okay.
No
So
point.
you could go to Greenwich again, which is you don't have to go into the city. You can go around the top to get to Greenwich.
Yeah.
But that's a possibility. The Narayan is at UPenn, University of Pennsylvania,
right?
And Geynisman. But what I would say is, if you've been on a holiday for 2 years and your PSA is up to 0.6, don't sit on this. You've got to do something. You need to know where you need a PSMA scan, and you've got to start thinking about how you're going to get back on.
Yeah, no, I understand. No, it's planned for early January. So
okay, but early January is 2 months away.
Right? You think that's too long a wait?
Yes,
huh?
It is too long. Don't let it go.
All right.
Dr. Jeff, you have your hand up.
So, Alan, are you unhappy with the care you're getting at Sloan Kettering in the city?
Am I unhappy? No, I am not unhappy. But, I don't have, and I only need to go in, in person once a year. For various reasons, I haven't gone in for a few years, but I have video calls every 6 months. So I'm not unhappy, but, I'd like to have a second doctor, even if it's just for an occasional check-in. I can't leave it all up to one doctor, no matter how good he is. I just, when you're dealing with something as serious as this, why leave it to just one doctor?
Okay, but you don't have the doctor you've been seeing is Chen, right?
Yep.
And I thought he was out in New Jersey at the MSKCC in New Jersey.
No.
Oh, he's in the city.
Yep. Yeah, he's in the city.
So you know there are 3 that I know of 3 Sloan Kettering sites in New Jersey.
Yeah, but they don't have the best docs, Jeff.
And that's correct. I looked at those pedigrees
They,
and all. It was weak. Otherwise, I would have done
they
that.
don't have the best docs, and then when you get with one of them, you can't switch, and it's a mess.
Right.
And I would say, and I don't know much about Chen. I think you're the only person we know who sees him. I mean, I would say it's not a bad idea to switch to somebody else. And if you're willing to go, to Fox Chase, Gainesman is a. Do we have any Gainesman men on the call tonight?
No.
Yes, not.
What about Matthew Zeibelman or Elizabeth Plimack or
Okay,
Farron
I
Murray?
don't have time to go through all of this. You have another question? We've
No,
given you a couple of
I'm not
names.
asking the second tonight. Let's leave it at that. I want to give others a
Okay,
chance.
we can go through all the other ones, but why not go to the ones that we like? We know they're good. And Gainesman and Orion definitely fit into that category. If you want somebody else in the city, we can come up with a name for you.
No, not right now. Fine, thank you.
Okay. Anybody else? Want to say anything to Alan? Anything on how long he should wait? Am I off base telling him he shouldn't wait till January, Len?
I wouldn't wait, personally.
Interesting. Okay, my doctor had some degree, he did have some urgency. I'm going to check on it. I always thought that with small PSA numbers, having a doubling time is not so relevant. I thought once you hit one, now a doubling time of 3 months is more realistic or serious, rather. Okay, low numbers, you just have what I call the law of low numbers. And, going from 0.01 to 0.02 is nothing. 0.1 to 0.2 is nothing. That's where I was coming from, but you all are telling me otherwise. And so that's fine.
Well, but that's because you're at 0.6 already.
Yeah.
Okay. If you're at 0.1, we might say, yeah, okay, but you're already at 0.6 and you don't want it to get to 1.2. And we know it's somewhere. And maybe it's time. Maybe we can handle this with spot radiation if we get to it.
No. But in my case, it was lung nodules, and there was no other evidence of metastasis anywhere else. So the question is, well, is it still there, which would be good, or has it gone elsewhere? That's the key question. I'll check on that and see if I can advance it. So
that's why we don't want you to wait too long.
Yep.
Okay.
Very good. Thank you.
Because you've been around us a long time. We love you and we don't want you going anywhere. Okay.
Thank you.
Okay.
Very
Steve
good.
Rue.
Well, I had two questions. I'm going to defer the second question for comments and remarks to next week. But the first question I wanted to know is from the moderators and the AnCan'r experts. Have you guys heard any information about when the ovarian and GYN group might restart? Has there been any rumors that they have a new sponsor yet?
There's been no rumors because we don't have a partner.
No partner yet. Okay.
We need a partner organization.
Okay.
And if we could find a partner organization, we do know that if we restart it will restart as a GYN group and not just an ovarian group.
Okay.
We have definitely made that decision. It is one of those standing items on my list with Alexa that we always talk about. We really want to do it, but we just need a partner. I mean, if somebody can introduce us to a small group, if anybody listening to the call knows a smaller GYN cancer group that would be willing to partner with us, we'll get it up and going right away. We've still got a list. But we will. Who's it for, Steve?
A very near dear friend of mine, a neighbor just a couple of houses down.
Okay.
She's kind of starting some kind of new thing that's.
Is it ovarian or is it ovarian or is it something else?
No, it's ovarian, and she didn't respond well to the platinum chemo, so they got her on some kind of new thing that's sounds pretty bad. Pretty.
So our former partner is supposedly running their own groups. And we
Okay.
didn't fall out with them. In fact, they made a very nice donation to us when they left. NOCC, the National Ovarian Cancer Coalition, NOCC.
Okay.
And I would, we don't have anybody there. The people we work with have since left, but I would reach out to NOCC, go to their webpage and see if they've got a virtual group she can join. We kind of trained them, their moderators, and then they sort of they thought they knew what they were doing, and then they decided to split and do it themselves.
I'll do that. Thank you very much.
But I'm sorry that, you know, like that's where we are with that one. And for you yourself, is anything important for you yourself, Mr. Rue?
No. I mean, the only other thing for me personally, for myself, is good news about my medications with the whole Medicare thing. And by the way, great blogs, Rick. Thank you very much for putting those in there. But the Orgovix gap for December, I have that covered through my Dr. Heath's protege. He filled me in with Orgovix through the whole year, so I'm done.
Okay. Now, I don't know, and this is for Richard Tolbert too, I don't know how they're going to be giving money out next year because it's all screwed up. And with this new 2000 cap, they really cannot subsidize you directly the way they've done in the past. And what we're hoping is that there will be, and there's a webinar next week, and I'll be asking these questions, but we're hoping that the organizations like PAN and PAF are going to be trying to help those people just based on money alone. In other words, based on your income, how much of that $2,000 can we cover? And that's not how it's been done in the past. But I don't know how nimble they are and if they figured out that that's what they've got to do. We do know for sure that you won't be paying more than $2,000, but $2,000 is a lot of money for many people. And so, what we've got to do is try and figure out if they're able now to make a means-assisted donation, a means-assisted grant to help you cover the $2,000, as opposed to worrying about how you're going to be paying $9,000 a month for the whole of the coming year, which was the former problem.
All right.
It'll
be interesting to see what they do.
Yes, I think I don't know. I mean, I haven't heard back, and I've reached out to a couple of people, and I'll know more next week. But I think they're going to have to rethink how they make these donations, how they make these grants, and spread the money around more evenly. And I think they can do it, but I don't know if they've figured it out. I mean, they may have all figured it out already, and they'll announce it, and we'll find out. But that's a question I'll be asking. Okay. And speaking of Richard Tolbert, you're the next one on the list, Mr. Tolbert.
I will be very brief, just to give you guys an update. I saw my oncologist and my radiation oncologist 3-month, 6-month visit. PSA is undetectable still after 3 years and 11 months in, and I'm still on Orgovix and enzalutamide.
How are you doing on that Orgovix and enzalutamide, senor?
I'm doing fine. I have I get a few hot flashes, not anything severe, but I do get a little tired sometimes, particularly if I see it in the afternoon. If I do my walk rather than in the morning, I get a little sluggish in the afternoon.
Now, you said to me you're 3 years and 10 months in, is that right?
3 years and 11 months.
Okay, call me Pisha. Let's say 4 years in. I do think, and you're undetectable. I do think you got to have this conversation about a drug holiday. I think it's time. Because we don't want that cancer to get too comfortable. In 3 or 4 years, we gotta do something to get it off balance. Drop the AD, drop the Orgovix, for example. I think I didn't hear you say that. We just go ahead. Can't hear me. Oh, there, now I got you.
Well, it went back that this conference is being recorded. I don't know what's going on.
Okay. Oh, I bet I know. I think you had a lapse in your signal.
Okay.
And you're back on. So I really think it's time you got to have a come to Jesus with your medical oncologist and say, look, I think it's probably time. You don't want to, 4 years, it's really the outside, right, Captain Jim?
Yes, it took me 5 years, and now I'm on 27 months.
Okay.
Although at this point, and with the PSA right now is at 0.06 for the last 90 days, steady. So at some point I will be returning, but not yet. It's been great.
I mean, the reason we feel strongly about it is because we've seen guys who have stayed on these drugs for too long. And then when they stop working, we cannot find anything else. Because the cancer's gotten so smart, it works around everything else. So we want to keep that cancer off balance.
Right.
And one way to keep, now, this is again, I can't remember, you don't see, you see a general med onc, right?
Yes.
Do you have any flexibility?
No, I do.
Go see Dr. E.
Okay.
You knew I was going to say that, didn't you?
I know.
You knew I was going to say that. Besides, you met her.
I did.
And she's so smart. And say to a Dr. E, don't you think I need a holiday? You know, that's Richard, seriously. I mean, you know, I joke around a little bit, but really, after 4 years, it's probably time for a holiday. And if you're with somebody like E, she's not going to let you get away from her. It's not going to get away, and it's probably around that time.
Will do.
Okay. Do you know how to get hold of her?
I do.
Okay. All right.
If I have trouble, I'll let you know.
Yes, and you can tell her office. Say Rick Davis said, I gotta see Dr. E, and then she'll say, okay, get him in quick. But really, you know. So we don't even have her on the call today. Where's General Joel? We don't have her on the call looking over his shoulder. All right, I'm going to keep. Anybody else want to say anything about the getting too comfortable with a treatment path? Any of our guys?
Well, Richard, what was your Gleason score?
I never had a Gleason score. I had a 453 PSA, and that's when I got all the PET scans and everything done, and went directly into the hospital.
Okay. Well, of course, you know, if you go on a drug holiday and you see the PSA starting to rise and you get antsy or anxious, you can always go back on, or at least talk to your doctor about what the next step would be.
But, you know, I like somebody like Dr. Eleni to manage that because she's smart with it. She's good with it.
Right.
She's going to keep you off for as long as she thinks is safe.
we'll follow up.
Okay. And let us know. Okay. I'm just making a note here. Okay. I think the next person is Took. Took, you got 5 minutes. What's the most important thing?
Hi, Rick. Yeah, I just wanted to ask if you or any of the members have any experience getting HDR brachy boost. I did convince my medical oncologist that based on NCCN guidelines that I should qualify for a for a brachy boost based on my T3 risk. So they don't have anybody who specializes doing HDR brachy in Southern California. So I have a call with a specialist up in Northern California in a few days. So just wanted to see if you guys have any experience or feedback getting an HDR brachy boost.
So HDR I don't, because I had low dose. But they do HDR as they told you they would do HDR. But they shouldn't make you go all the way up there. You can tell them, no, I'm not going to go up there. If HDR is the right treatment, I want to do it down here and go see Albert Chang at UCLA.
Yes, my radiation oncologist is supposed to be the regional chief of Kaiser. So he looked at everybody in Southern California and he recommended me to seek advice and a consultation with Northern California. And I looked up this doctor and he is with the American Brachy Society. So he seems
okay,
to
but that's not the point I'm making. You can get HDR brachy in Northern California, but you live in Pasadena, right? Where are you?
Yeah, I'm in Pasadena.
You're in Pasadena. If they don't have a doctor in your area, they have to send you out to somebody else in the community. They don't need to make you travel to Northern California. Even if they don't have somebody, you can, within your rights and at Kaiser, you can say to them, no, I don't want to go up there, and this is the treatment I want, and I'm entitled to this treatment. And you've got a very, very good practitioner at UCLA.
Oh, okay. Like Dr. Albert Chang or something? Is that
Yes.
the person? Oh.
Yeah. So could you get it up in Northern California? Yeah, you could. You could get seats up there too.
That's the option that was presented with. So,
well, that's the option you were presented with because that's what they want you to do because it costs them less.
Oh, okay. But you're saying I do have a right to go out of network
if they don't have a practitioner in your area, in your network, and your network is Southern California, you can go out. They don't have to make you go travel to Northern California to get treatment. Now, in Southern California, they could make you travel to San Diego from Pasadena if that's where the person was, but you don't have to go Northern California. You don't have to go 300 miles to get your treatment in Kaiser.
I mean, yes, because I did look. Yeah, I looked up at the ABS, all the doctors on the American Brachy Society membership, and there weren't too many within. There weren't any Kaiser doctors in Southern California. So
right. So here's the discussion to cut to the chase. Okay. Can you get HDR? Yes. You're eligible for HDR. Should you have HDR? Yes. They agree. Now, you can then insist and say, I want my HDR locally. I don't want to travel.
Oh, okay.
Okay? And you don't have anybody locally, so I would like to go and see Dr. Chang at UCLA, who's an expert in HDR.
Okay.
So you have to advocate for yourself. And they're going to say, oh, no, but you could go up there. Well, but this is what Kaiser does.
Okay. Okay. Yeah, well, yeah, thanks for your feedback. I'll see what they say. But yeah, but I'm still going to meet with the doctor. I mean, I got a video call with the doctor, so I just want be interested to see what he says and stuff.
Does he do it in one session or two?
I think it's only one session, like 15 gray, based on the NCCN guidelines.
Okay,
So
don't worry about the grays. It's not going to make any difference to you. Don't worry about the grays. Worry about, is it one session or two sessions?
Oh, okay, yeah.
That's what all you should care about.
Okay.
Right?
Okay. Okay.
But for me,
so no big. Go ahead. Sorry.
For me, if Kaiser said, yes, you are entitled and it is the standard of care and you should get HDR, then they have an obligation to provide it to you in your area within Southern California. They can't send you to Northern California for their convenience.
Oh, okay. Okay. Yeah, yeah, because I did have a medical record number with Northern California at one point. So yeah.
That's got nothing to do with it. You are now a member of Southern California Kaiser Permanente, right?
Oh, okay. Okay. Yeah, no, I didn't realize. I thought I just had to stay within the Kaiser network since it's an HMO, and I wouldn't offer any out of network.
The issue is that the Kaiser network is split into several divisions. So you have Northern California, Southern California, Washington, Virginia, different places. Now, they have rules that make it convenient for them where they won't send you to somebody in a different group if it doesn't suit them. So right now, somebody in Southern California can't get to see Dr. Hartstock because she's in Northern California. The fact that you're in Southern California and they want you to go there is to suit them. Because then they don't have to pay UCLA anything.
But do you think if I
okay,
advocate for UCLA, that's going to drag my treatment on for like months?
You have to tell them that it shouldn't be months, and you have to advocate for yourself. This is about advocating for yourself at Kaiser. And sitting down with your doctor, calling this radiation and saying, I've been thinking about this. I don't want to go up to Northern California and I want HDR brachy. I'd like to get it here in Southern California. And he's going, we don't have anybody. And you say, right, well, then we'll go out of network if you agree that's what it's for. Okay. And when he says, sorry, can't do that, you say, well, yes, you can. It's not that, this is what you're supposed to do. You're not supposed to be making me travel. Unless you want to have your guy, or tell him, unless you want to have your guy come down here and do it down here somewhere. But this is about advocating for yourself, too.
Okay, well, thanks. Yeah, I'll see what they say. Thanks.
Okay, but be prepared to stand up for yourself here.
Will do. Thank you.
I've got, who have we still got? We've got Dr. Jack, we've got Alfredo, Andre, and we've got Jeff. Oh, and then we've got Steve Collins and we've got Brian Hack. We've got a lot of people still. I'll stay on for as long as it takes. I'm not offended if you drop off, but I will stay on to get through everybody. Dr. Jack.
Okay, I'll be brief. There were several things I wanted to talk about, but I'll keep it within 5 minutes. So I saw Dr. Belusic today, and fortunately my PSA is still undetectable. My absolute neutrophils are still much too low, 1.43, which makes me crazy. But The thing that we reviewed my FDG scan, it's been read by several people as being no evidence of metastatic disease anywhere, which is good. And, I'm not getting a PSMA scan until my PSA rises. So, it's not an absolute diagnostic test in terms of seeing whether or not I still have some active metastasis, but nothing is showing up in my PSA in the blood. What he wanted me to do, he's doing a new study with his affiliation with NIH, and he asked me if I'm willing to volunteer in a clinical trial. Foundation Medicine is collaborating with NIH, and what they're doing is they're doing a non-DNA sequencing quantitative analysis of your tumor burden, and it kind of picks up the amount of cancer antigen you're holding in your body. And he wanted to know whether I want to be tested every 2 months. And I gave it some thought, and I said, well, I certainly see the upside because I want to take a holiday at 18 or 24 months, most likely 24 months, because the ADREAM study hasn't been completed yet. So I'll go with the 24. They don't have results where they can tell me the sweet spots at 18 rather than 24. So I said, I'll volunteer, but I got a little nervous, I said, because the upside is that if it turns out that I have no DNA done in my blood from this foundation study, that it'll give me more comfort associated with taking a vacation, a holiday in June. But on the other hand, if it does pop up that I have it, it would make me hesitate a little more, which made me reluctant. But then I didn't want to put my head in the sand and say, I'd rather not even deal with it. And so what I'm going to do is I'm going to volunteer, and they're going to draw blood every 2 months, and I'm going to find out whether or not I can stay clean up until June, and then I'll take a holiday and cross my fingers. So I just wonder how you guys would feel about, becoming going on trial with Foundation Medicine and NIH to see whether if you're clean and you're someone like Jim Marshall, who's been clean so long with a 0.06 PSA, whether you'd want to be followed with this DNA sequencing to see whether or not you have any microscopic antigen, cancer antigen in your body.
Go ahead, Jim.
I say absolutely. The more I know about me, the better off I can make decisions.
I agree. How about the rest of you guys? I mean, I think it's a great test. Have you heard of it, Rick?
I have, actually. I was on a website. I was on a presentation from Natera last week where they were talking about ctDNA, and I'd like to see it employed for people who where they suspect micrometastasis. And Len and I actually were talking about this a little bit, going back and forth about CTC, circulating tumor cells. But circulating tumor cells, which is sort of what they pick up and then break down for the DNA, is kind of a less specific than the ctDNA. The ctDNA, from what I understand, is at a finer level. And the people that are really leading that field, from what I understand, are Natera, Natera.
Well, I contacted Natera 2 years ago when I couldn't find what was going on and where it was located, and for some reason or other they didn't want to continue doing it because I couldn't get any tissue. That's before my biopsy, and they needed fresh tissue, and they couldn't get it out of Sloan Kettering. So
well, they need the fresh tissue so they can personalize the test so they know what they're looking for.
Right.
But I don't know if they can look for stuff without the test. Maybe that's what you have to find the DNA. Otherwise, that you just draw the tumor out. I don't know. Len, do you know the difference between finding these circulating tumor cells and finding ctDNA?
Yeah, there is a distinction there. I don't think that the source of ctDNA is collecting whole circulating tumor cells and then breaking them down. It's two different things, I believe.
Right.
So Jack, are they doing ctDNA or CTC? Which one are they monitoring? Do you know?
I didn't get that. He told me it's going to be more sensitive than PSA in picking up whether or not I've got, I thought antigen, the first thing that came into my mind. I didn't know what else to call it. But for my tumor, because I got, low volume at this point, and I just want to see whether there's anything microscopic that could be present that I'm not aware of. So
there was a recent, they did a recent study showing that tracking the number of CTCs, circulating tumor cells, whole cells, correlated with prognosis. So that if you were, less than 5 CTCs, you're in pretty good shape. If you had more than that, there was a poor prognosis. So I don't like the idea that if all you're telling me is my prognosis is good or bad, but there's nothing you can do about it, that really doesn't help me too much. Unless, of course, it says you've got a good prognosis.
Right.
But anyway, yeah, I would ask Belusic, what exactly is it that they're looking for?
Yeah, I'll have that explained to me. They're going to come by and they're going to draw my blood, and I'll ask a lot of questions if she's able. If it's only a technician who knows nothing,
No,
then I won't be able to
forget it.
Yeah,
If foundation medicine is coming by to draw your blood, they use a service. Those people will know nothing,
We don't
Jack.
know anything. So all I know, this is new. This is not the usual. It has nothing to do with sequencing or just tumor burden. And like they do as part of the package when they do the usual sequencing of circulating DNA without taking somatic tissue. And he said it's new. And this is something, because he was with NIH for so many years, he's been asked to do it.
Okay,
a number of other doctors.
Jack. Right now, foundation medicine doesn't do anything with ctDNA. They do with circulating tumor cells. That's what their liquid biopsy does. So they're able to filter out the circulating tumor cells, which they then break down and analyze to see where the mutations are. That's how my understanding is that's how they do the blood biopsy sequencing.
It's not what they're doing. He told me.
Right.
What
they're doing for you is they're looking at ctDNA, which is a whole nother ball game. They're trying to pull out the ctDNA, and this is what this trial must be about.
Right.
That's what we're guessing, right? Which is what Natera is doing, except Natera is doing it based on knowing what they're looking for. And now Foundation Medicine's trying to do it. Would it be helpful? Yes. But the other issue is, how are you going to respond to it? And that's really the big issue. Now, in your case, you've already answered that and said, well, if they don't find any ctDNA, then I might be ready to take a vacation. And then I can keep doing it. And then I'll stop my vacation when they start finding it. So there is a treatment. You have a treatment strategy.
Right. Well, I asked him, are there any false positives or false negatives? He said, no, that's what you guys are going to tell us. So evidently, part of my being in a clinical trial is to make a determination, the degree of false positives, false negatives with other patients besides myself.
Okay, your time's up.
Okay.
Come in number 5, your time's up.
Good
okay? Sorry. Got to keep moving along here. Dr. Alfredo, we got all the doctors at one time here. Come on, Dr. Alfredo.
I'll just be really quick. It's just an update.
Yes.
Last week I had a fun time with general anesthesia, placement of fiducial markers and a substance called Barrigel, which is a competitor to Space Ore. Some of you may have heard of. It's basically a plastic type substance between the prostate and the rectum, makes a little space there. And then on Thursday of this week, I'll have my first of 43 IMRT treatments. And I'm looking forward to getting that started. See, I did it in less than 1 minute.
Very good. Very good. That's because you know how to, that's because you've done it with patients that way.
Yeah, that's
And
absolutely
you get
right.
them out of the office, right? And you move them on to the next one,
Absolutely right.
right? So they put the barrigel in, and remind me, they're going to radiate the prostate and the pelvic girdle and across the pelvis or not?
No, just the prostate, because my PET scan showed only prostatic activity, my PSMA PET scan, my MRIs and CTs likewise. Interestingly enough, on the day after I had the fiducial markers placed, the barrigel placed, I had a CT and an MR simulation to make sure they could line everything up. I've got little tattoos all around my pelvis, but I believe the plan is prostatic radiation only. The other thing I'll mention is Dr. Choi mentioned to me that he's expecting I'll be on Lupron for a year, and then we'll see. And I think by then Eleni will be in charge and we'll move forward. But I'm optimistic about the whole thing.
Why did you decide to do this in 45 sessions rather than 5 or 4?
I didn't pick, Dr. Choi picked. It sounded reasonable to me. I didn't make a fuss about it. Don't ask me how many gray it is because I forgot.
No, I wasn't going to do that. That's Took's department. You know, I don't understand why. First of all, 45 is a lot of grays, and it sounds like that includes a boost. To me, it sounds like it includes a boost. It's usually 20 to 25 plus another 20 to 25 in the boost.
Okay, that could be. Hasn't been mentioned to me. I'll ask.
You need to ask. And the other is, we can take care of that with SBRT today in 5 sessions, at least half of it in 5 sessions. But if you don't mind going back and forth to MD Anderson, that's okay.
It's about 30 minutes from my house. I'm going to take Lyft or Uber. So in a sense, I mind because it's a lot of sessions. And in a sense, I don't mind because I have the blessing of residing here.
Well,
lucky.
I think that the question I would be asking Dr. Choi before you start next week is, why aren't we doing some of this with SBRT, Dr. Choi?
Okay.
And maybe we can cut the sessions. Maybe I still need some of this, outside of the gland. I need it in the small fractions of the IMRT, but why am I doing all the rest of it when I could get that done in 4 or 5 sessions? Okay. I mean, Mac says 4 sessions. Actually, Mac, if what they're doing is what I think they're doing, Mac would say 2 sessions plus 25 sessions for the IMRT, Mac Roach. But you need to have a heart-to-heart with Choi and find out why he's got you slapping back and forth for 45 sessions.
Okay, I'll ask.
Alfredo, what is your Gleason score?
4+3, 1 needle out of 12.
So we're happy to have you here, but I'm wondering, why are you in an advanced prostate cancer group when?
Oh, because recurrent, because I had focal laser ablation in 2020.
Ah, okay.
And I guess, you have to ask Rick. I tried the other 2 groups, and people said, "Oh no, you're in the wrong group. Oh, you're still in the wrong group. Oh, go to advanced and recurrent." So that's why I've been here. So I guess Rick am I right? It's the recurrent that gets me in here, right?
Julian left us. Did Julian leave us? You're the same situation as Julian, yes. And when it comes back after focal, I think it's better off in this group than in the other group, Len.
So Len, that's the answer to the question. That's why I'm here.
Okay.
But please check why he's designed it this way. There may be a good reason for it, Alfredo.
Okay.
But if we can save you 15 trips to on Lyft and Uber, and we're in for 10% of that, we have an interest.
Yeah, I'll find out what I can. I'll let you know.
Thank you.
Thank
All
you.
right. Keep moving. Keep moving along here. And Andre, you're still with us. Good for you, man. What's on
I'm
your
hanging in there, Rick. Yeah, thanks. It's been some time since I've been with you guys. I was talking to you after the high dose brachy, and then I dropped off as I did the 25 sessions of IMRT over at Moffitt in Tampa. That all went well. I'm about 6 months in on the ADT, and I'm running into some side effects, and I just wanted to pick your brains real quick. I'm not turning on my camera because I got to go through some different screens on this phone, but
Okay.
I think I have mastaglia, and I'm wondering if that is does that then lead to gynecomastia as far as that side effect. I've been on Orgovix for 5 months, did Cassidex for the first month, and so it's getting me a little kind of concerned. The other side effects that other gentlemen are mentioning, the hot flashes and whatnot, haven't been as a burden to me. But before I get back with the oncologists at Moffitt, I wanted to see if anyone had any suggestions on how to deal with this side effect, some kind of an estrogen blocker. Dr. Scholes at PCR, I had mentioned on a video the other day, used Femera, and the doctors here are thinking radiation or what's the other stuff it's called? Give me a second. Tamoxifen. So I don't know if anyone else has dealt with this problem, of the breast enlargement kind of thing.
A bunch of these I'm sorry to ask you, or you can put it in the chat room, because I'm trying to pull up your record and I don't find it. You'll have to remind me of your last name. You can put it in the chat if you don't want to put it on the recording. So the easiest, best thing to do is get 1 or 2 radiation blasts to your chest.
Okay.
But you need to do that earlier rather than later. So it may be too late, but that's probably the thing that's going to do the best for you. Okay. Everything else is going to have some sort of side effect if you take it, whether it's the tamoxifen, whether it's one of the estrogens, etc., etc. Took what's on your mind on this subject?
Oh, no, I was prescribed a anastrozole, 1 milligram. It's a little bit less stronger than Femera, because I asked for Femera, but my medical oncologist only gave me the 1 milligram of anastrozole. I think the brand name is Atrimix or something like that.
Okay,
So
what were you asking him? What was the reason you were asking them for this?
Oh no, that's the meds I was prescribed for his gynecomastia, for my gynecomastia.
Okay, but did you had gynecomastia as a result of your treatment?
Yeah, even my primary care doctor said I had mild symptoms. So,
but how long have you been on hormone therapy? Not long.
Probably two months. But I was showing signs of my chest kind of cupping, so that's why I asked for it. But I got
that's unusual. I mean, it's real unusual in fact, I would say that's a first for me. How about for you, Len, that somebody's dealing with gynecomastia after 2 months?
Yeah, very unusual. And did Andre say he already has gynecomastia, or he just wants to prevent it?
I want to prevent it. I have tenderness and pain, But I don't mind the tenderness and pain if it's just a side effect that will go away once I'm done with my 18 months, being 6 months in. I just don't want it to lead to gynecomastia. I just didn't know if the pain is indicative of that's what I've got to look forward to. And I better hurry up, like Rick said, go get some radiation.
Yeah, that's the simplest way. Get a couple of zaps. That's what I would do. Talk to them about just getting a couple of zaps. It's a much easier way, and you're not putting any of these drugs in, the estrogen blocker drugs, because they can give you grief too. It's a much better way to deal with it. Jim Marshall, you had your hand up.
Well, anyway, the thing was, I was curious about anyway the cup size. Okay, at this point, but I'm hearing that there isn't any problem yet. So
right.
So when I look at myself, I see differences, but then I've got fat distribution that I didn't have before because of the ADT. I haven't really gained that much weight, but it's coming on. I think I'm losing muscle mass and replacing it with fat because I've been too lazy to do enough exercising like Rick told me to. But so I don't know if it's just fat deposits or if it's the onset of what we're talking about. But I do have that tenderness and pain in the chest, so I don't want it to progress either way. So my radiation oncologist has offered to do that. I just wanted to get some.
That's what I would. David Muslin, you know a little bit about this one.
I do. I wish I would have done it earlier because I waited too long, and then there's not a lot I can do. So the earlier you do the radiation, the better off you are.
So it's literally just a couple of visits of zapping, and that's it. Not like the 25 I just went through for the.
No,
just a couple of zaps.
Some guys do it in one session. Some guys do it in two. Some docs do it in one. Some docs do it in two. I've actually talked to a cardiologist who says he doesn't think that there's any downside from it at all. I asked them specifically. Jeff Marchi.
Yeah, I just was going to mention if you've got BRCA2, you probably don't want to do that. I went to check with a radiation oncologist, and he told me that since you can get breast cancer with BRCA2, they would not be able to treat it if they did that. So that just something to think about.
Yeah, I got the genetic testing for heritage. I don't think I have that. I think I'm okay with that, but
yeah. Okay. I mean, BRCA2 can complicate stuff, and it also makes you a lot more sensitive to the radiation, so you have to be careful with BRCA2. But
so would it be the radiation oncologist taking lead on this, or the medical oncologist that suggests I do that?
Well, it would be the radiation oncologist who does it, and between them, they decide on the dose, I suppose. I don't know.
Okay.
I'm not really sure.
Okay. I don't want to take any more time.
I think the order would have to come. The order would have to come from your medical oncologist.
Okay. Very good. Thank you, gentlemen. Appreciate the input.
Andre, whatever you do, stay away from Casodex, bicalutamide. That is the worst drug for gynecomastia.
Right. I started that, when they first diagnosed me. Then I switched to Orgovix, which is another antigen, as opposed to the agonist.
Yeah.
So I'm in a similar modality with this, but I guess there's not enough data out there to compare the two.
Well, it's not really similar. There are two different types of drugs. One blocks the testosterone receptors. The other one blocks it prevents the testes from producing testosterone. So you should be okay with the Orgovix. Most people are. But something like 70 to 80% of guys on Casodex develop gynecomastia if they're on it for any length of time.
Okay. Well, yeah, I'm not going back to Casodex. Lucky enough to get the Orgovix. So I'll get with my radiation oncologist. He's the lead in my team there. So hopefully I can be fit in pretty quick here before something grows that I don't want to grow.
Yeah. It's also it's also a little unusual, but not unknown, that you dealing with gynecomastia if you're only on that single drug, on the Orgovix, but it does happen.
Yeah, I have too much heart risk, family heart risks to go with the second tier stuff that they're,
Okay.
going to suggest. I didn't want them to, anyhow, that's aside.
Okay, got to move on because we're
Yes,
really
thank
late.
you.
Jeff Marchi.
Hello.
Hello.
Oh, just a couple of quick things. One was
One quick thing. That's all we got time for. One quick
I
thing.
just going to mention I stopped Orgovix after being on Lupron for 7 years and Orgovix for 9 months. Harstark agrees that my testosterone is never going to come back, so might as well stop it. But I was wondering, does people here have urinary incontinence problem if they're over 70? What
Hold on,
percentage of people have to go to the bathroom more than once a night?
Okay, let me just understand what you said. You're staying on the darolutamide, but you're going to darolutamide monotherapy. Is that right?
Yep.
Okay.
Because my testosterone is never coming back after 8 years on ADT.
Okay, I just wanted to make sure I understood that you're going to darolutamide monotherapy.
Right.
Okay, and you want to know if people are dealing with incontinence?
Yeah, well, once a night I have to get up, go to the bathroom. And that's probably because I take a couple of pills just before I go to bed and I have to take 8 ounces of water. So a couple hours later I have to go pee. But I've got somebody who said 80% of men over their 70s have to get up more than once a night. And I'm just wondering what people's experience with that is here. If other people notice that have the same problem that this guy says, or is once a night or none a night more common?
Okay,
Any idea?
Jim Marshall.
Okay, let's see. I'm like 80 years old, probably anywhere from 2 to 4, because provided that I happen to wake up and I think I have to go, I get concerned that I should get up because I don't want to pee in the bed. So it's more out of, well, if I get up and go, I can go back to sleep easily. So, yep, old age, you just don't.
What do people find about, if you're over 70, what's the frequency?
Dr. Jeff.
Yeah, Jeff, if you're getting up once a night, I don't think any man over 70 should ever complain that they're getting up just once a night. I mean,
so you
once
think
a
it's
night
very
is like
common.
sleeping through the night.
So it's very common to get more than once for men that age to have to go more than once.
Without a doubt.
Okay.
But if you're just getting up once a night, you are so far ahead of the game. You're in such a good place.
Yeah, well, I'm not, and mine's because I drink 8 ounces of water just before I go to sleep. So 2 hours later, I got to go. But if I didn't do that, I probably wouldn't have to.
Right.
All right. I just wanted to get a verification whether or not people over 70, it's very common they have to get up more than once a night.
It is very common, yes.
Okay.
Here's a
So
solution for you,
common.
Jeff. Drink. Why don't you drink your 8 ounces 2 hours before you go to sleep?
Well, because I need to take gabapentin and Tylenol just before I go to sleep so that I can sleep. I don't get pains while I'm sleeping. 2 hours ahead, and the stuff is the timing's wrong on the gabapentin, and the Tylenol doesn't last long enough.
All right,
All
so
right,
you're going to
guys.
get up tight to fish. Okay.
Guys, we think that Jeff's got a good problem. He doesn't think so, but the consensus is that many people would like his problem. All he's got to do is figure out how to take. And the other thing I would suggest is, do you really need 8 ounces of water to take those 2 pills?
Well, I
So,
might take 6 ounces, but I'll still have to get up if I do that. I mean, it's
okay,
like,
well, what about 4 ounces? Cut down on
no,
the
no,
amount of water.
then you get acid indigestion. That's
Okay,
the problem.
so
Tylenol gives me indigestion.
there you go. All right.
All right.
Now, I think Matt has left.
Oh,
Has
move
Matt
on.
left? Yeah, Matt has left, and we've still got. Oh, wait a minute, Doug. We had Doug. You were going to give us a quick update. Did you find a medical oncologist, Doug?
I talked to my urologist, and Kaiser has this little quirk about they don't assign them unless I'm metastatic, which didn't sound right to me at all.
But
And
you were going to go
what
through
happened-
the VA. We knew you weren't going to get it through Kaiser. How
Right.
are you doing
What
with
she
the
did
VA?
do is she put me back in touch with a radiation oncologist. What happened is I had one, of course, for my radiation treatment, but that doctor left, so I was without any oncologist at all. Anyway, so what I'm doing on the side is I am working with. Well, I have requested of my nurse navigator a second opinion with Dr. Graff, and I haven't had a response on that yet, so I will see.
Okay,
But
so
I know
that's
that
your nurse navigator at the VA, not at Kaiser, right?
no Kaiser. No, she was really good initially. She got me an out of system second opinion on my first go around at my request, which was it
Okay.
couldn't be
I
done.
just
It had to be
look,
done on
I
referral, but
just
it couldn't
I
be done
just
with a
want to
referral.
tell you, maybe you'll get it, maybe you'll get lucky. It's very, very difficult with Kaiser, and I would use the VA system where you can probably get a community referral. Captain Jim knows about this, but that's how I would get to Dr. Graff, especially since she works with the VA.
So,
Okay.
so I try to get her phone number directly, or do I go through her through a VA primary care, or how do I reach her?
You go, Captain Jim will have to navigate you, but usually you've got to go to your primary care in the VA. They will refer you to the urologist, and then the urologist will refer you to the medical oncologist.
Okay.
Okay, that's the system I know. Am I right, Captain?
Yes.
Okay. Well, I thought if I could get in as a second opinion, I might be able to go direct, but I'll give it a try.
Well,
I'll
you
try both
can,
routes.
but I just know how difficult that is at Kaiser. But if
Okay.
she thinks she can do it and she can cut through,
Yeah.
try it. But we've never had much luck getting outside referrals from Kaiser for GU medical oncologists. And we've been
Okay.
doing this a long time.
Well, since I have started that, I will also just start seeing if I can get a primary care at VA and start working that route.
I think that's certainly what I would be doing.
Okay. So I have that radiation oncologist appointment tomorrow, and I also have a genetic counselor appointment tomorrow. And Jim is helping me with getting some paperwork in for benefits. So
Okay, but get yourself a primary at the VA so you can start moving through that VA system, right? And
Okay,
don't
will do.
expect any joy on the medical oncology from the radiation oncologist at Kaiser.
Okay.
They'll short shrift you.
Well, if I don't get referred directly to PSMA, then I attest, then I am certainly going to be pushing hard on the VA. Yes.
That's right.
And
We had to get you a PSMA test, right?
I think that's a great idea. Yeah, since I'm at a 0.75 PSA.
Yeah, that's right. Thank you for reminding me. Yeah, I mean, you might be able to get it off of your. Did you raise the PSMA with your urologist?
No, I didn't think I wasn't going to get anywhere with that. So I thought there was a possibility with the radiation oncologist.
That's true.
I mean, it's really the bailiwick of the urologist at Kaiser to do it.
Oh.
and they should be doing it. It's the urologist's job to order the PSMA rather than the radiation oncologist.
Okay. I will
Because
find out
they
tomorrow.
are managing your treatment instead of a medical oncologist. So that's where the PSMA would come from, usually.
Okay. She didn't seem very willing to do that, so that puts me back in the VA.
Yeah. Well, that's not a surprise, but they should be doing it.
Right.
Okay. I'm going to keep going. Sorry to short shrift everybody, but it's getting very late. Steve Collins, sorry to keep you.
No problem. I've been blinking in and out on my Nexus. I hope I'm able to stay. Well, I was just a little follow up. October 30th, I met back with my urologist, and they started me on Orcovix.
Yep.
And one of the questions I had, but I found out before we started tonight, one was that something the VA would approve, but they have already approved the medicine and shipped it out to me. God, one of the Dr. Alfredo said, I think we at the same spot. Like I had a right by my lymph node in my pelvic area, but they want me to start Orcovix for about 2 months. Then they want to radiate. They told me 40 rounds too.
Huh.
I guess, I don't know.
Yeah.
But also here you say,
well, I'm just an internist.
I'm working with a radiologist.
So the only thing I can, and I started my anti-androgen therapy 4 months ago. So 4 months before the first dose of radiation. And my speculation is that what they're going to say is that there's some theory that says many small doses is thought to be better than fewer larger doses, because that's part of the difference between SBRT and IMRT. But I don't want to speculate because it's not my expertise. I want to ask the oncologist.
Yeah, but the trials don't bear that out.
Yeah.
Because they've done trials on that, and I'm not the expert on this one, but they've done the trials, and it's not, and the SBRT is non-inferior, but it's all a question of what area they're radiating, and for you, Steve, they're radiating across the pelvis. It's in the bed, right?
Yes, sir.
You had you had a radical prostatectomy back in 2013, right?
I had to
remove. Right. So you have a completely different situation. So
yeah, I never had a prostatectomy. I still have my whole prostate.
That's right. So
okay.
So
yeah, I have prostatectomy.
The reason you would have to get 40 sessions or less, you're not a candidate for the SBRT.
Okay.
Because the reason Dr. Alfredo is because he still has a prostate. Okay? Now, where I'm confused is they said they started you on the Orgovix. However, they got you the Orgovix, but they don't want to start you until after the radiation. Is that what you said?
No, they want me. The radiation oncologists want me to take the Orgovix at least 2 months before.
Right. That's how it should be.
Okay.
Okay. So go ahead.
No, I was just saying the urologist said I would be on the Orgovix at least 12.
Okay.
Go ahead, Steve.
Can you still hear me? Okay, no, I was cutting off. I said the urologist wanted me to be on the Orgovix 6 to 12 months.
Right.
And then we'll do the radiation and I guess go from there.
So wait a minute. The urologist suggested stay on the Orgovix for 6 to 12 months, and then we'll deal with the radiation. The radiation oncologist said do it for 2 months, and then we'll do the radiation. Is that what you're saying?
Right.
Right. So if you,
The,
I mean, if
the
they can,
radiologist, the
if you need the
oncologist.
radiation, then I would say the radiation oncologist sounds like he's making more sense. That's what we always hear. We're not trying to get rid of the metastasis just with the hormone therapy.
Right. He said I need
You're breaking
both.
up on
He
us
would
a bit,
recommend it.
Steve,
He said
so
it was
it's
standard
hard
across.
to hear you. I would.
Yeah, it just for some reason my service just keep the last 20 minutes just keeps going in and out. But I was saying that he's saying that it's common practice that I do both. I have a better. He said I basically have a chance of maybe even cure if it happens. Could you hear me?
Steve, turn off it with the camera. Turn off the camera and it will improve
The sound.
your audio. There we go.
Okay. Can you all hear me
There
now?
we go.
Yes.
Maybe.
We can hear you.
hear me
Can
now?
you hear us?
Yes, I can.
Okay. So what we're saying is the radiation
I
oncologist
was
makes
just
more
saying
sense
that
to us than does
I
the
don't know what.
urologist.
So I guess my other question is, sort of holding, should I find me what you kept saying, a GU medical oncology? Or I'm good with just the radiation oncology.
Yeah.
Well, you're doing all this through the VA, correct?
Correct, through the VA.
Through the VA. If you can get the radiation, but the radiation oncologist is not at the VA, he's somewhere else, right?
He's outside, right at North Side in Atlanta.
Right,
He
he
sent
sent
me
you
out
out
to
to
the
the
community.
community. So who is the quarterback for you for your prostate cancer at the VA?
Probably a urologist.
You asked me who was the
For
quarterback
your prostate cancer at the VA. Who's calling the shots?
I have never had a doctor at the VA get me straight. They sent me straight out to the community. I never worked with a doctor at the VA. They just approved for me to go to the community right away.
Who is they? Was that your PCP or was that a urologist? Who approved that?
Yes, my
Your PCP. Okay. So
yes.
I would like, if it were me, I'd like to have a genitourinary medical oncologist on my team. One problem for you is that there's a shortage in Atlanta. We don't have a lot of good choices in Atlanta. I would have to ask Dr. Mark who we would send you to in Atlanta because it's not great. So, because we don't want to be asking for a community referral to a medical oncologist if we don't even have a name, because then who knows who they're going to send you to. I would probably say, let's just get through your radiation and hormone therapy right now with Dr. Benton and see where you stand. If you've got a lot of side effects from the Orgovix, then yes, you will need a medical oncologist on your team. That's not the area of expertise of the primary care doc. And it's probably not the area of expertise for Dr. Benton. And we would have a good case to make that you need an expert doctor to help you manage the hormone therapy. But why don't we see how you do on that? And you'll tell us. And if we need to come up with a name, we will. We'll go back to Dr. Mark, who knows Atlanta well.
Okay, appreciate that.
Okay.
Plan.
It's always good to have a plan.
Yeah.
All right. Before I'm the only one on here, oh, Brian Hawk, you had an update for us.
Yes, Mark, Rick, can you hear me?
Yes.
All right, my connectivity sucks, so I've got you on just my audio. So, first of all, I got to thank you and all the other members here for your guidance and sage words of wisdom and pearls of knowledge, et cetera, et cetera. I had a video meeting with Dr. Kaysen at UCLA, and he said he feels comfortable with an SBRT on the lymph nodes that are in my retroperitoneum, and we're going to do that over 10 days. It'll be 5 treatments every other day, and I also was accepted as a new patient with Dr. Reddick. My MO up here says he's totally comfortable with letting UCLA call the shots. They did start me on Eligard and enzalutamide. My PSA dropped from 19.5 to 1.4, I believe it was, but my testosterone hasn't budged. It's like 411. So I'm going to get another PSA and testosterone and see just what's going on. There was no Casedex, no Orgovix. We just went straight to the jab, so to speak. And but a testosterone flare. The testosterone flare should have lived out its. My PSA and testosterone were taken about 6 weeks after I started the Eligard shot, the 3-month Eligard shot. And it's kind of interesting. So we'll see. There may be some adjustments. But yeah, that's pretty much all I got to report. And also, I just want to tell the guys that Mark's right. Sorry. Rick is right. We have to be our own best advocates in this ordeal, and more information the better. But if you don't speak up, you're not going to get the care you deserve.
So let me ask you a couple of questions, because
I'm confused.
Who gave you that first Eligard? Who prescribed the Eligard and the enzalutamide?
Yeah, that that was locally. So he went. I did some.
Okay. Hold on.
Yeah, that was locally.
Hold on. That was locally. Okay, and he did not give you bicalutamide first. He didn't give you Casedex before the shot.
No, he said it wasn't needed.
Well, that's ridiculous, and that's malpractice. God forbid you would have had a flare that and some metastasis in your back when nobody saw. He would have been in deep caca. And and these docs drive me nuts. I mean, they know they have to do it. It wasn't needed. How does he know it wasn't needed?
Rick, I swear to God, my gut was telling me this is wrong. As I brought it up to him in that initial conference, mind you, I've left my urologist, but there's a medical oncologist, mostly general. I'm in Idaho. We only have general MOs. There's no GU MOs. And my neighbor 2 doors down, she's a general MO, and I asked her about this guy. She said, yeah, he's really good, but she originally wanted me to see this old short query whiskers, which I approve of, but I couldn't see him for however long. And this other younger doctor who's pretty sharp, like very sharp, I decided to go with it, and I did drill down on that. It's like, why are you not worried about having a testosterone flare? And so he said, we got to get your testosterone, down. And honestly, it pretty much started me on the enzalutamide at the same time. So maybe he wasn't worried about the flare if my receptors were blocked. So that's how I rationalized it, but I didn't want to sit there and have a, debate.
Okay. Yeah. And so Dr. Kishan is going to do the SBRT to radiate these retroperitoneal lymph nodes. And
correct.
And how long have you been on the Eligard?
I'm gonna say we're about 7 weeks into that, and about 5 to 6 weeks into the enzalutamide.
And when was your testosterone last tested?
Oh gosh. I'm sorry I didn't come prepared for these questions. It was actually lower than 411. I can tell you that. Which the 411.
How long ago did they test your testosterone, Brian?
Oh, only a few months. I've been doing it about every 3 months, so it's been between 409 and 300 and something. Okay. Yeah. So
let's try this again. You got your Eligard shot 7 weeks ago, right?
7 weeks ago, correct. Roughly 7 weeks ago.
Have you you said they tested your testosterone after the Eligard shot, correct?
Correct. About
how many weeks after the first Eligard shot did they test your testosterone?
I'm going to say 6.
Well, it should have moved. It should have moved by 4 weeks.
Yeah, but the only thing that moved was my PSA, which went from 19.5 to about 1.4. So at least the receptor inhibitors are working. I'm not so sure the Eligard is working.
The Eligard's working.
Well, the Eligard's not working if he had a 411 testosterone after 6 weeks on Eligard.
That's my thought.
But that's really weird.
But the receptor inhibitors seem to be working. I would say.
Well, maybe, but I think you need to get another testosterone as soon as possible and to figure out.
Yeah, I'm getting a repeat test done. Let me check my calendar. I'm so sorry. I had all this time to prepare and I totally failed. PSA lab draw November 11th. So, next week, Monday next week. So
yeah, you need it sooner rather than later because this is weird stuff and
stuff. Yeah.
And the doctor who's giving you this Eligard shot, he should be asking for it. He should have followed up again. But anyway.
Yeah. No, he was the one who asked for it, Rick. I apologize. He's, because I'm preparing to go to UCLA on the 20th to have my simulation test at 8 in the morning. This is all happening on the same day. 8 in the morning, I go get the sim test for the SBRT. 9:30 in the morning, I go see Dr. Reddick, and about 12:30, I get a repeat PSMA PET CT. And I really am so glad I got hooked up with. First of all, I got hooked up with you guys, and you guys pushed me in the right direction. And UCLA has really worked out great. I love Idaho, but this is UCLA has the brain trust and technology and high tech imaging, which is what I needed.
Right.
Because I'm
recurrent. How did you find us in the first place?
I belong to a Facebook group, and we do a Zoom meeting every Wednesday. it's more of it's run like an AA meeting. So it's a support group, but this is a knowledge, based, science based, more knowledge based, and I'm past the shock and awe and anger and denial phase of my cancer journey. So I need more. I'm metastatic, so I'm, stage 4. I need to drill down on this and stay on top of it. And so I'm just looking. I looked outside the box and found you guys.
Okay.
But your recommendations I followed, and I am very pleased so far. I'm extremely pleased.
Yeah, I'm just. You're the perfusionist, right?
Yes, the certified clinical, CCP. What
Right.
We're crazy people, certified crazy people. I think is how I would describe ourselves. But yeah, working with cardiothoracic surgeons for over 30 years can drive you nuts. But I'm a happy person.
Okay, so just keep us posted. I'm glad that there were no adverse events, and you'll see Reddy, you'll see Keishan, but you gotta find out why your testosterone isn't falling. That's very weird.
Well, the Eligard worked. When I was on Eligard for 18 months. In fact, I almost asked him, well, if you're not going to give me, because I did obviously ask for the Orgovix, but I had such a horrible reaction with welts and swelling and stuff from the Firmagon, which also acts like Orgovix, and I really didn't want to do that. And if I would have started on Orgovix, it would have delayed the process. I mean, they had a shot ready for me, and versus do I have to beat the bejesus out of the insurance company?
Okay.
Yeah. So I just said, F it. Let's give me the jab. Let's get this thing started.
Okay.
So I was getting a little anxious. I'd be honest with you. It was partially my fault.
Okay. All right. I'm gonna call it a day. Jesus, it's.
Don't even look. Don't even look.
And Took, come back, Took. What are you getting yourself all wrapped up in your TMB and your MSI, man? Are you there still?
Oh yeah. I'm here. It was.
You're making yourself crazy with stuff you don't need to worry about. I've been telling you this from the beginning. You're not there. Thank God.
My medical oncologist. I did get my medical oncologist to order a somatic test for me. So I guess they're sequencing my slides. So
okay, well that's a good. The sequencing is a good thing. This was the medical oncologist at Kaiser.
Yeah, he's actually a fellow, so I was dealing with. So
okay, well it's a good thing. So then we'll have. But don't worry about your MSI and your TMB at this point in time because you're not there. We don't need to get that stuff.
Okay, yeah.
All right.
No, I'm okay.
Rick, can I ask Brian one quick question, please?
Of course you can, Dr. Jeff. Anybody who stays on this long is entitled to ask any. In fact, Dr. Jeff, would you like to? Can I pass the moderation on to you at this point?
Brian,
yes,
Eligard is given subcutaneously. Are you sure that this last shot was given subcutaneously and not intramuscularly? Because it could explain, if you give it IM, it's not going to work. It's got to be given sub-Q.
Yeah. So they gave it to my backside, so I wasn't able to see whether or not they gave it a sub-Q injection. I will ask that question, Dr. Jeff. I appreciate you on that. because it is kind of boggling. In fact, I'll even send it on a portal question. I assumed the nurse knew how to do it, but
Don't assume it, and they're not gonna give you the real answer. They're gonna say, of course it was sub-Q, but when a shot like Eligard doesn't work, you have to wonder, was it absorbed?
Yeah.
You know, it's a long-acting sub-Q shot, and if it's not absorbed, it's not gonna do anything.
Yeah, because I've had it in the past and it's done tremendously well.
Right, but
So,
it has to be given correctly.
yeah, and I'm you know what, because of your concern, I am going to reach out to the doctor tomorrow morning with that
So I would
question.
suggest
exactly.
one thing. The next time you get an Eligard shot, let them give it to you in your abdomen, sub-Q, so you could see how it's administered.
Yeah.
There's a whole lot of people who give shots the wrong way. My medical career, I saw it time and time again, and it's like you're not getting the drug.
Yeah, well, when they did the Firmagon in my gut, I watched them do kind of the wagon wheel, and you know, they did it correctly. And by the way, ice is a great local anesthetic, and I just iced my whole chest, and I'm like, all right, ladies, go for it. That was my, you know, that was my go-to for dealing with the duration of which they stick a needle in you, which really bothered me. But anyway. Yeah, I will reach out to them and say, I think you fucked. I'm sorry. I think you may have, you know, done a IM injection. Let's fix it.
Yeah, I would do that.
I think that's a great suggestion. Thank you, Dr. Jeff.
Good pickup, Jeff. Good, very, very, very good pickup. So,
absolutely.
So, yeah, so the Eligard is subcutaneous and the Lupron is also subcutaneous, correct?
Lupron I get within and with the muscle within the hip.
Oh, that's right. Yes.
Eligard's within the fat, of the belly, and that's how I've always.
Okay.
Not in the fat. It's given into the skin, subcutaneous.
Oh, well, okay, into the skin. Well,
sub-Q.
Sub-Q. Okay.
So here's what I'm thinking. I should have known that because I had enough of those damn Lupron shots, and those go in the muscle. I bet she gave you an Eligard shot in your butt because that's where they usually give them, the Lupron. And she was thinking it was Lupron and it was Eligard, and she gave it to you like a Lupron shot.
Yeah.
Yeah.
Are you saying that Lupron is IM and Eligard is subcutaneous?
Yes.
Yes.
Oh shit. Okay. I'm calling them tomorrow. I am calling to tomorrow, and I'm going to say I had a brain trust to figure this out where you couldn't. So
yeah, I should have. I mean, I was thinking that the Lupron was. I was thinking that the Lupron was IM because I had enough of them to know.
Lupron,
I always thought Eligard was the same.
Lupron should be the same way. Lupron and Eligard both should be sub-Q.
I would think so, but
both should be sub-Q.
I don't know.
I've gotten Firmagon, I've gotten Lupron, I've gotten Eligard, now I'm getting Lupron. You want them all to be in subcutaneous shots. But I will still bet, Rick, that when they gave him this Eligard, they did not give it sub-Q.
I agree.
They went deeper, and it rendered it ineffective. Because, I mean, physiologically, you shouldn't have a testosterone of over 400 6 weeks after a shot.
No, right. All right, guys, I got to beg off.
Yeah, appreciate you guys. Great discussion tonight.
Okay. Good night, everybody. Thank you for these stalwarts standing around.
Thank you very much, Rick.
I'm
night,
closing
guys.
the meeting. Good night, everybody.
All right. Have a great week.
Thank you. Good night.
Night.